Good morning. Hi. I'm Joshua Morganstein. Welcome to everyone. By way of introduction, I'm a member of the American Psychiatric Association Committee on the Psychiatric Dimensions of Disasters. I'm also a Commissioned Corps Officer in the United States Public Health Service, a captain there. My day job is as the Assistant Director at the Center for the Study of Traumatic Stress in the Department of Psychiatry at the Uniformed Services University. I also serve as Assistant Chair and an Associate Professor in that department. My colleagues are going to talk to you about a range of aspects related to what is a very broad topic with many salient aspects of mental health and its relationship to climate change. To sort of set the stage, my bent and my focus has to do with the overlap between extreme weather events, so natural disasters, and a changing global climate. And so that's the focus of in the work that I do, both with the APA and at the Uniformed Services University. So this is a picture of Harvey, impressive view from space. I'm sure folks are well aware of the considerable number of what seems to be an endless supply of adverse disaster-related events, unfortunately both human-generated and natural, that cause a range of untold suffering. And I think one of the important things for us as psychiatrists to take away in a discipline that frankly has been largely in no small measure marginalized, behavioral health in the healthcare field, but not surprisingly in the world of disasters. Even as recently as 9/11, in a human-generated disaster, the idea that behavioral health needed to be a part of that process was really sort of foreign and considered a kind of ancillary, secondary type of issue that really needed to be relegated to later on and to second tier and was not as important as other things in a disaster response. And frankly, literature is showing that both the expense and the human suffering of disasters are overwhelmingly psychological and behavioral in nature. And our discipline, our profession couldn't be more critical to ensuring the well-being of a population, preparing for and responding to disasters. So just to sort of orient us, disasters come in different flavors. They're human-generated and there are natural disasters, and there are different types of human-generated disasters, and occasionally they overlap. Or they're combined disasters, things like Hurricane Katrina. That was a hurricane that really caused devastation as a result of failed infrastructure, much more so than the hurricane itself. Or Fukushima in Japan, where an earthquake followed by a tsunami caused a nuclear reactor disaster. So these sort of complex, multi-type disasters can certainly bring with them a whole host and a range of different concerns. What we're going to be talking about, and what I want to focus on, are disasters that have the greatest body of literature in terms of their association with a changing global climate. And those are meteorologic, hydrologic, and wildfires. So we're talking about things like blizzards, cyclonic events such as hurricanes, heat waves, droughts, and other things of that nature. There is increasing evidence that's sort of looming out there around the role of changing global climate in precipitating geologic events, so earthquakes. And so some of you may be familiar if you've read science, if you're a reader of Science and other similar journals, you may be aware that some of this research is kind of popping up. For the federal report, which I'm going to share with you all, that I was a co-author on the mental health chapter for the president, we needed to leave geological events off the grid in 2014 and 15 when we were developing the report, because the evidence simply wasn't strong enough, and we needed to go with things that really had the highest confidence level. So what we're talking about, again, meteorologic, hydrologic events and wildfires, and again, no shortage of those recently. So for those of you who might be saying to yourself, and it's probably less in a self-selecting group who's at a climate change activity here at IPS, but when you're talking to your colleagues who are psychiatrists or other mental health professionals who say, I live somewhere where there's not a lot of disasters, I don't think I'm going to don't think I need to know about this disaster stuff. I hope, no matter where you're sitting in the room, that this information from the Center for Research on the Epidemiology of Disasters, which shows increase in severity and frequency of meteorohydrologic disaster events globally from 1950 to 2012, conveys clearly that this is a significantly increasing phenomenon. Not just in terms of how often they are occurring, but in terms of what it's costing us. And this is the red line is cost in 2012 dollars. So people have argued, well, there's increased coastal living and more people living on the coasts over those 62-year period of time. That's why it costs more. Well, housing infrastructure and our ability to prepare for and build disaster-resistant housing has theoretically increased considerably over that time period as well, and yet it's costing dramatically more. So the likelihood of you being involved in, and I'll show another graphic later on, having to deal with, manage, respond to, assist in some capacity, you, your loved ones, your patients, in your career is high. Dr. Lewis talked a bit about various types of psychiatric disorders, and I actually want to reframe our conversation very briefly. This is one of the more important takeaway slides, I think, for us as psychiatrists. So there are a range of well-identified psychological and behavioral responses in the wake of disaster, climate-related disaster events, and there is a considerable body of literature over decades that substantiates this. And the circles in this Venn diagram are sized according to frequency. If I could make the red one a lot bigger, it would be. But it's to convey to you that psychiatric disorders, while they do occur, and they do cause considerable morbidity and mortality in the wake of climate-related disasters, and the tail of that, what tends to affect populations most significantly in the wake of disasters, and that we need to be on the lookout for, are distress reactions and health risk behaviors. So imagine a population that is poorly slept, that is irritable, that is avoiding other people and isolative. Those things, when they happen, and in the wake of for instance, of 9/11, the National Sleep Foundation found that across the country, not just in New York or in DC, but across the country, 50% of adults reported disrupted sleep for at least a 2-week period of time that they attributed directly to that event. So the disaster community is not just the physical location where a disaster occurs. Many people are exposed to the effects of disasters, media, friends and family, and other things. Distress responses are important for us to be aware of for a couple of reasons. One, because they're so significant, but two, because how many of you have had someone wander into your office complaining simply of a sleep problem? Do people walk in to see psychiatrists just to say, I'm sorry, I'm here just because I can't sleep? That's it. Where do people with sleep problems show up? So I'm a family physician and a psychiatrist, and I can tell you in my family practice, I have 10 to 20 times the number of people wandering in, and when I rotate and work in emergency departments, that goes up even more, complaining of sleep than I ever did wandering into my psychiatric practice. Distress reactions and health risk behaviors overwhelmingly are likely to present where our colleagues work in primary care and emergency settings. And this sort of goes to one of the points I hope to send to you all, that disaster psychiatry is about collaboration. So we as mental health professionals, as psychiatrists, have a lot to offer our colleagues in primary care and in emergency medicine to help them understand that this wave of sleep problems coming into their ER following a disaster may not actually just be single one-offs. If you're an ER doctor and somebody comes in with a case of tuberculosis, you bet that they're well trained to report that as a potential public health issue. 100 people coming in complaining of sleep, they wouldn't even bat an eyelash at. So psychiatrists need to help them understand that they could be looking at population health, public health issues in the wake of disasters, these things that will easily slip through the cracks in those environments. I'll also mention, Dr. Lewis mentioned to you all, shared some important studies that have shown variability in things like suicide rates following disasters. And this graphic will give you a little bit of information to help understand why this is a relatively predictable phenomenon. In the wake of disaster events, particularly those that affect communities, broadly across communities, there is a well-established psychological and behavioral series of phases through which communities tend to progress. It isn't always linear, and it doesn't always happen exactly in this fashion, but this is a prototype. A colleague and mentor of mine who works at our Center for the Study of Traumatic Stress was the director of disaster mental health for SAMHSA for about 10 years as his sort of pinnacle job in the 1990s. Was on Air Force Two with Al Gore and his wife, unfortunately to both Columbine and Oklahoma City bombings, and worked both of those events on the ground for weeks or months at a time. And he was part of helping SAMHSA develop this as a model for how to consider what happens psychologically and behaviorally to communities in the wake of disasters. And one thing I'll point out is that you'll notice that the functional line, the vertical axis, at the end of a disaster, the line is a little bit higher. And that was SAMHSA's attempt to convey to people that disasters don't have to be all bad, and that many people grow as a result of disasters and develop what some people might term post-traumatic growth, but an enhancement in their ability to function and a belief in their own capacity to manage through difficult events. So we have these different phases, a heroic phase, a honeymoon phase, and the time period that Dr. Kessler, for instance, and his colleagues found post-Katrina, when they looked at the 5-month mark, the 3 to 5 month mark for suicide rates, is that they were down. They were lower than average for that same area. But when they came back in the 12 to 18 month range, during what we know to be more of a disillusionment phase, and was for those communities, the suicidal ideation rate and suicide attempt rates had gone up and were now statistically significantly above the baseline rate in that community. So the honeymoon phase brings with it a lot of positive things, a belief that things are going to get back to normal, resources, help, a common and shared goal, and shared difficulties where people collaborate and work together. But it's followed by more difficult times. And so understanding the phases that a community goes through, we as psychiatrists can help community planners, disaster managers, leaders in our community, healthcare systems, to both respond appropriately at each of the given phases, as well as to provide anticipatory guidance about what to expect, what's to come. And knowing both of those things is very powerful in helping to promote wellness in a community. Many of us have had the misfortune of responding to a patient in an emergency setting or a crisis setting inappropriately, either overshooting or undershooting or watching someone do that. And we can certainly escalate things. The same can happen for communities. So a failed response or a poor response, the wrong thing at the wrong time, can actually increase distress for communities. So this is powerful information that we as psychiatrists can help people to understand who are responsible for managing. I'm going to only mention briefly, because the next speaker is going to talk in more detail, but a discussion about disasters would be incomplete without mentioning the issue of people who are more vulnerable to disasters, sometimes termed special populations, those who may require special consideration in the preparing, responding, and recovery phases of disasters. And I like to think about vulnerability in terms of pre-event demographics, vulnerability related to event characteristics, as well as the recovery impact. And one of the significant aspects about vulnerable populations in disasters is that they overlap almost to a T with populations that are uniquely vulnerable to the adverse effects of a changing global climate. So vulnerability to climate change is essentially vulnerability to the extreme weather events that occur as a result of it. This is a list of various vulnerable populations. Again, I won't talk in too much detail about this, but it's helpful for us to have our sights set on people who may benefit from increased attention, resources, assistance, and support, both before, during, and after disasters occur. So we talked a little bit about the problem. I'm going to talk real briefly about some things that I'll share with you or offer you to take away that you can do. The first would be learning more about the issues, about disasters and the changing global climate. On the left is the federal report, which hasn't been taken down as of last week from the website, so grab your copy while you can. Another EPA resource page, unfortunately, that I used to share here on presentations has a "we'll be back" message on it. I don't know when that'll be back, but we'll see. This report, the impact of climate change on human health in the United States, was the first report of its kind, and it was a follow-on to the third National Climate Assessment These climate assessments are driven by the US GCRP, US Global Change Research Program, which was written into law congressionally in 1988, if you can believe that. We've been dealing with and looking at a changing global climate by law for almost 3 decades. And so in anticipation of the 4th National Climate Assessment, the President wanted a document that really looked at what evidence do we have about the scope of the problem. What the document doesn't do is talk about what to do about it, and that was specific. We did that specifically. It was an attempt to identify the scope of the problem. So for folks who want to understand the scope of the problem from health in general, it's a wonderful document. You can take a look at our chapter in particular on mental health and well-being, and that will give you more focused, specific information. And a wealth of references. So it is a well-referenced resource document that consumed tens of thousands of person hours to develop and scrutinize through, as well as a very extensive public comment period. The other thing you could take a look at is the map in the top right, this DisasterViz website that has FEMA data by county around the United States. You can interactively select different types of disasters, specifically climate-related disasters, to understand which ones your region where you live and work and your patients reside are most common. What do you most likely need to prepare for or be ready to address or help your patients to address? And you'll also note, just like the earlier graphic I showed you, that the frequency of these events is clearly increasing on the scale at the bottom. Another document that might be useful to you is a disaster behavioral health curriculum that myself and Dr. Flynn, who I mentioned earlier, developed in conjunction with the National Center for Disaster Medicine and Public Health. This is essentially a framework document that lists a variety of areas that disaster experts believe are helpful, useful to be knowledgeable about in terms of preparing, responding, and recovering from disasters. And they are mapped to what we believe are seminal resources to help you directly go to information. So if you wanted to know, how do I do this health risk and crisis communication thing, you would simply look that topic up on the list, and next to it would be articles, a book chapter, a technical report, that kind of thing, a URL that quickly guides you to useful and, as often as we could, freely accessible resources that will help you both learn for yourself as well as to develop educational material for other people that you may need to teach. But these are ways that you can kind of expand your knowledge about both climate and mental health as well as disaster mental health. I would also suggest that, and people will talk later on about issues related to resilience and building resilient communities. There is also, what's also very important is to think about the immediate aspects of preparing yourself and preparing your practice to respond to disasters. People fear things that they do not understand and feel unprepared to manage. So we can decrease the distress in our patient populations by helping them to feel more prepared and helping ourselves to feel more prepared with some basic interventions that are very tangible, that don't cost a lot, and that don't take a lot of money or time. For a provider, understanding what your role is, if you want to be involved, are you going to be a consultant? Do you want to be a clinical care provider? Do you want to be part of a responder team? What sort of role do you want to play in the response to and management of disasters? What does your practice need? Who might you want to partner with? Are your record-keeping systems something that's going to allow you to continue to maintain a practice or your patient's well-being in the wake of a disaster that may involve interruptions to power and utilities and other things like that? And helping your patients. How many of our patients know what their have a family emergency plan? Know what happens if there was a disaster that involved their school? Or know what their work emergency plans are? Or have things like an emergency go kit with simple things like a flashlight and water, battery-powered radio in it. Or have really trusted, and increasingly so in today's society, trusted sources of accurate information. And then do's and don'ts after a disaster. Telling your patients, after a disaster occurs, turn off the television. Your kids shouldn't be staring at this stuff on the television and on their social media feeds all day long, because that just increases their exposure load. These are real basic and pragmatic things that are very tangible that we can offer to patients. Many people are familiar with psychological first aid. I share this only so that people who might be interested in this article can take a look and pull this. This is the framework of how we recommend intervening in the wake of a disaster. Things that promote safety, calming, self and community efficacy, connectedness, or hope and optimism are to be encouraged. And the reason I mention this is because disasters are chaotic and people will come up with all kinds of interesting ideas. I spoke with a colleague who managed one of the evacuation centers yesterday in the Texas area, one of the 2 large centers, and some very interesting lessons learned about what's always a chaotic situation. But we have to filter people's bright ideas through the lens of, do they promote these things? If they do, then we should keep them in the list to consider. And if they don't, then we need to scratch them off the list right away. Other biopsychosocial interventions for people. So psychoeducation and normalizing things. I think many of us understand this because we do this in our practices clinically. This is critical for people in the wake of a disaster. Understandable reactions to abnormal stressors. It's not you that has that's wrong. It's the situation that human beings are not designed to tolerate. Enhancing social support and things like basics like optimizing sleep and enhancing calming. And I would encourage people to lean heavily on psychosocial interventions, behavioral interventions for people, because those promote efficacy, things that people can do for themselves, and certainly sleep medication at times, because that will help calm arousal and help people feel more calm and more safe. So I'll also mention communication, and I think Dr. Haas is going to talk a little bit more about the science of communication, but better than any medicine, information treats anxiety in a crisis, and we all need to be thinking about communication as a behavioral health intervention. It isn't simply something we learn to do with patients, it's something that helps manage populations. And again, I'll refer to our sort of current political climate, where there's no better example of how the way in which leaders communicate can decrease the distress for populations or increase the distress for populations. We can advise people, community leaders, disaster responders, and help be in their ear if we have these kinds of partnerships, or be part of the process, the discussion at the table, to help people understand that there are principles of how you communicate. It isn't something that you freewheel. When you get in front of the microphone is put in front of your face. That's not the time to start thinking about how you map and create messaging, because those have very significant consequences on our populations and their well-being, and that's our area. So we need to be protective of that, supportive of that. Support to leaders is something that our center has worked a lot with, particularly in the military, but we have done a great deal of it in the civilian sector as well. Leaders need help. They need to understand how to manage grief. They need to understand health and risk and crisis communication. They need to understand self-care. These are things that are often unaddressed or poorly addressed in the wake of disasters, and they have significant effects on populations. There's good data that shows that the perceptions of how people are led in the wake of disasters has a significant effect on the trajectory of things as specific as the development of post-traumatic stress symptoms. How did I do?
Great. So we will have questions. We'll take 1 or 2 questions right now, and then a little bit more. Is that okay? I would say think about this. In particular, maybe later on, Josh, you could talk about the fact that there's a formalized disaster response setup that people need to know. If you're going to be a responder, you need to know what the structure is for disaster response. And we'll have some more questions about that. So thank you so much.